لسه مش محمر بتاع الدكتورة ميسة محمر. خلصت المحمول يا طارق؟ خلصت المحمول ولا لسه؟
كل حاجة.
اتكلم شوية كده عبال ما تخلص. بسم الله الرحمن الرحيم. Dear friends and colleagues, it gives me great pleasure to join you today in this symposium. It's important symposium. It's hot symposium, and it is interactive session. And it's my great pleasure to co-chair this session with my friends and colleagues, Professor Samir Khidr, Professor Maisa Sharafuddin, Professor Ashraf Hatem, and it's also a very golden chance to re-thank Professor Tariq Safwat, Professor Hatem for the organization of this very good Congress. And as you know, as a physicians, we frequently encounter patients with severe uncontrolled cases of chronic obstructive pulmonary diseases, despite all the available therapeutic options. These patients continue to be exposed to a high risk of serious exacerbations, and it is a pleasure to, as I told you, to co-chair this session, important session. We have three eminent speakers. We have Professor Tariq Safwat, Professor Tariq Mahfouz, and Professor Hatem El-Mallawani. And as you know, the burden of chronic obstructive airway disease is underestimated because it is usually not usually recognized and diagnosed until it is clinically apparent and moderately advanced. This is our practical daily experiences. Prevalence, morbidity, mortality in Egypt, it's very high. It's not accurately estimated, but still every day we have a significant new cases of chronic obstructive airway disease. COPD is, in Egypt, is a significant health problem. Now it's both in men and women. The economic costs of COPD are high and will continue to rise in direct relation to the ever-aging population, the increasing prevalence of the disease, and the cost of new and existing medical and public health interventions. The last report of WHO, the number of mortalities last year worldwide from tuberculosis is 2 million. The number of deaths from chronic obstructive pulmonary disease are 2.2 million. And the deaths from lower respiratory infections is 4.3 million. In 1990, the ranking of COPD was number 6. It is expected to be number 3 in 2020. I am sure that all of you and me personally looking to hear our eminent professor, Dr. Tariq Safwat, and his presentation, inhaled corticosteroids, LABA, or inhaled corticosteroids, leukotriene antagonists. Please, Professor Safwat.
Bismillahirrahmanirrahim. Thank you, Mr. Chairman, for your nice introduction. Well, my task today is to review with you the asthma management, the ICS LABA versus the ICS LETRA. That's an important issue for us, and I'm going to address this in my presentation. As we all know that low doses of ICS rapidly improve the clinical symptoms and measures of lung function. This is the cornerstone of our management. That's the inhaled steroid. That's the major task, that's the major issue, that's the major management. The long-term use of ICS has a positive impact on long-term outcome, achieving suppression of airway inflammation and markedly reduces the frequency and severity of exacerbation and asthma mortality. So it's mainly acting on the inflammation. And ICS are the cornerstone as well for therapy for persistent asthma of all degrees of severity in adults and children, and early therapeutic intervention is really recommended to start with. So we're not confusing people about the ICS. ICS is the major cornerstone of our management. Patients, however, patients who continue to experience asthma symptoms despite taking regular inhaled steroids represent a management challenge in our practice. And long-acting beta-2 agonists and leukotriene receptor antagonist agents may both be considered as add-on therapy to our treatment with the inhaled steroids. If we're going to revise the several reasons to support the synergistic effect of either combination therapy at the cellular or pathophysiological level, we're going to look here. The LABA would definitely reduce the airway hyperreactivity. While the steroids will increase the expression of beta-2 adrenergic receptors, which is a good combination and a good synergistic effect. So we're all familiar with this combination. On the other hand, the LETRA would inhibit the production of cysteine leukotrienes, which are important, as we know, pro-inflammatory mediators in asthma. And actually, the leukotrienes are unaffected by the steroid treatment. So it's important as well to add in our treatment to consider the leukotriene receptor antagonist. And LETRA are particularly effective in allergen exercise, and especially in the 15% patients that we know they can develop a kind of idiosyncrasy with the anti-rheumatic agents like aspirin, etc. So the addition of leukotriene receptor antagonists or long-acting beta agonists could potentiate the anti-inflammatory effect of inhaled steroids and can lead to a better asthma control, as we are all familiar with. So if we're talking about how much benefit can be achieved by the combination of ICS with LABA or ICS with LETRA, that's a question mark in our practice. I'm going to revise with you the Global Initiative of Asthma, just a quick revision. Now it's the latest GINA 06, we're all familiar with it. It's controlled, either partially controlled or uncontrolled. And these are the major characteristics to have a proper control of asthma. Daytime symptoms should be controlled, limitation of activities, nocturnal symptoms, need for reliever or rescue medication, the lung function should be normal or near normal, and the exacerbation should be none. This is the well-controlled population, which unfortunately we don't have it much. And these are the uncontrolled. If you have 3 or more features of uncontrolled asthma present in any week, this will be put into the category of uncontrolled asthma. And this is the new guideline, the treatment steps 1 to 5. And now the new guideline, the GINA guideline, it depends not on the severity, it depends on the controlling the symptoms of asthma. So that's the major issue here, that we have treatment steps. We should educate our patients. We should have a proper environmental control. And of course, the step 1, you either use the short-acting beta-2 agonist, but you have the option as well to put some controllers in this category. Anyhow, usually we rely on the short-acting beta-2 agonist. Step 2, we select only one, which usually is the low-dose ICS. But anyhow, some of the pediatricians, they can put the leukotriene instead of the ICS. So this, you can select one of them. Preferably, we prefer the inhaled steroids. And then the steps 3, 4, and 5, it's an add-on treatment. Usually the step 3, it's low-dose ICS plus LABA. And in the step 4, we can add one of these on the high-dose ICS with the long-acting beta. We can add the leukotriene. And then we have the step 5, which is the oral steroids with the anti-IgE as a new treatment. So this is the last, or this is the latest guideline. If we're looking here on the long-acting inhaled beta-2 agonists, the LABAs, the long-acting inhaled beta-2 agonists are most effective when combined with inhaled steroids. We're familiar with that. And addition of LABA to a daily regimen of ICS would definitely improve symptom score, will definitely decrease the nocturnal asthma, would improve the lung function, it will decrease the use of short-acting inhaled beta-2 agonist. We can reduce the number of exacerbation, and we achieve a clinical control of asthma in more patients more rapidly and at a lower dose of ICS. So it's a nice duet to use both of them. And just a quick message that this is the steroid. It will act on the receptor with an anti-inflammatory effect, as we know. It will increase as well the expression of beta-2 receptors. And the beta-2, if we add the beta-2 agonist, it will help in bronchodilation, and it will affect as well the priming of the receptor by removing the heat shock protein 90, so it will help activation of this receptor by using less steroids in the management. This was a study on the 1 second FEV1, and just a comparative study. Of course, the FEV1 improved with the high dose budesonide plus formoterol. In this is the curve, and the FEV1 will be less if we have a lower dose of budesonide, higher dose. Anyhow, combination of a beta-2 long-acting beta-2 agonist with an inhaled steroid, whether it's a high dose or a lower dose according to severity of asthma, will give a better result. This is as well the formoterol and budesonide in moderate asthma, and if we look here, the severe exacerbation is per patient years. With the budesonide 200 milligram, it's much more than using the budesonide 800 microgram per day with the long-acting beta-2 agonist. So definitely we have less exacerbation if we're using the LABA with the inhaled steroids. Now, what about the leukotriene modifiers' role in therapy? The leukotriene modifiers include the receptor antagonists like montelukast. We don't have the xyluten, which is the lipoxygenase inhibitor. It has some side effects on the liver. Clinical studies have demonstrated that leukotriene modifiers have a small but a bronchodilator effect, and very well, this is according to the GINA. Some patients with aspirin sensitivity can benefit from adding the leukotriene receptor antagonist, and we know that about 10 to 15% of the asthmatic population can develop a kind of idiosyncrasy to aspirin. So if you just put the Letra in your management, it can help those patients. When used alone as a controller, the effect of leukotriene modifier are generally less than that of low dose of inhaled steroids. And in patients already on inhaled steroids, leukotriene modifiers cannot substitute for this treatment without risk. And we are familiar with vasculitis, which happened with the Church-South syndrome for patients receiving steroids for a long time and then stopping immediately, or all of a sudden the steroids, and switching to Letra. And they develop this kind of syndrome, which is Church-South syndrome with vasculitis. So if we're using leukotriene with ICS, the leukotriene modifiers used as add-on therapy may reduce the dose of inhaled steroids required by patients with moderate to severe asthma. They may improve asthma control in patients whose asthma is not controlled with low or high doses of inhaled steroids. And several studies have demonstrated that leukotriene modifiers are less effective than long-acting inhaled beta-2 agonists as add-on therapy. So this is some of the recommendations of the GINA. And I'm just going to review with you the Cochrane review, which is the effects of long-acting bronchodilators versus leukotriene modifiers as add-on therapy. The Cochrane review reviewed, there were more than 10 papers. They reviewed the LABA with the ICS and Letra with the ICS. And these were the results. The current review compared the relative benefits and safety profile of adding Letra or LABA to patients with asthma who are inadequately controlled by ICS. So they reviewed the papers, and the comparison was mainly on exacerbations, functions, biomarkers, and symptoms. This was the Cochrane review. Many trials were there, 9 trials for which evaluated the effects of Letra versus LABA as add-on therapy, trials on exacerbations, trials on lung function, and trials on biomarkers. I'm sorry, it's a very busy slide, but this was to compare meta-analysis comparing the LABA versus all of these studies the patients were receiving inhaled steroids. But this meta-analysis, many studies were included in it. They compared the morning peak flow of the LABA with the ICS versus the LETRA with the ICS, and they showed here that there was definitely an improvement by using the LABA with the ICS, considering in comparison or concerning the pulmonary function, the morning peak flow. Same thing happened with the evening peak flow. The studies mentioned that it was better by using LABA with the ICS than LETRA. The FEV1, that's the total meta-analysis result, was better. This is a comparison of the Montelukast here. That was the Zafir-Lukast. So I'm just gonna review the points of Montelukast. There was definitely some improvement with the FEV1 with the LABA with the ICS. And the rescue-free days, more or less, I would say it's close to the median line, but anyhow, it goes towards the LABA, that the rescue-free days, the percentage rescue-free days were better than with the LABA, with the ICS, than with the LETRA with ICS. But anyhow, it's not that much difference. The quality of life, if you look here, the quality of life, LABA with ICS, was much better with the group receiving this kind of combination instead of the LETRA. So the quality of life was much better. Symptom-free days, I would say in this meta-analysis, it was more towards the LABA, but anyhow, it's very close to the median line. So the symptom-free days, I would say that LABA ICS or LETRA ICS are more or less comparable, but it's more towards a beneficial effect with the LABA. But anyhow, the end result is more close to the median line. The night awakens as well, it's much less with the LABA with the ICS than the LETRA. And exacerbation rate, frequency, the subtotal was more or less equal. So these were the Cochrane review about the difference in management between the LABA, ICS, and LETRA and ICS. What we can say that the addition of LABA was consistently superior to LETRA in improving lung function. This is a cornerstone, and we have to put it in our mind that LABA would improve definitely the lung function for the asthmatic population. And clinical implication in symptomatic asthmatics with impaired airway caliber and receiving inhaled steroids, the addition of a LABA would appear definitely appropriate. If you have a wheezy chest, the patient having bronchospasm, adding on steroids, the LABA would be really consistent in our management. However, in those persistent asthmatics with normal airway caliber, which have quite a good population of these patients, they have a normal airway caliber, receiving inhaled steroids, the addition of LETRA would appear logical in order to attenuate the underlying inflammatory process and relieve symptoms. We know that asthma is a variable disease, so we have to be flexible in our management. We have to be flexible and to tailor our management according to the patient and according to the variability of asthma. The take-home message that the addition of LABA was consistently superior to LETRA in improving lung function. It's very evident. In symptomatic asthmatics with impaired airway caliber receiving inhaled steroids, the addition of LABA would appear really appropriate in our management. Considering our leukotriene modifiers with the ICS, LABAs are potent bronchodilators, we know that. The true anti-inflammatory effects have not been defined. They are bronchodilators. We cannot mention that they're really anti-inflammatory medication. Indeed, they are not labeled as anti-inflammatory agents. They are bronchodilators. LETRAs are not appropriate first-line therapy for patients with moderate or severe asthma. We wouldn't put it at the first line. We have to start with inhaled steroids. In addition, even in patients with mild persistent asthma, the potential long-term risk of inadequate control of inflammation must be considered until further data are available. The letters appear to have a kind of additive effect with the inhaled steroids and may therefore lead to improved asthma control with a lower steroid dose and in patients with moderate and severe persistent asthma. And thank you so much for your attention.
شكرا للأستاذ الدكتور طارق صفوت on his good and comprehensive explanation concerning the addition of long-acting beta-2 agonist or antileukotriene or versus antileukotriene to inhaled corticosteroid, and his notification that long-acting beta-2 agonist is more superior when added on inhaled corticosteroid to restore the lung function. It is my pleasure to introduce for you my dear colleague, Professor Tariq Mahfouz, and his presentation, Asthma COPD, if they are one or two diseases. Professor Tariq Mahfouz.
Shukran, Mr. Chairman. First of all, I would like to thank Novartis very much because it gives us the chance to debate two of highly scientific non-pharmaceutical issues which are still points of debate among all of us. Professor Tariq Safat highlighted the point of ICS-LABA and ICS-LETRA, and still I think that there will be a lot of discussions around this topic by the end of this session with our eminent chairman. But my issue now is to debate whether asthma and COPD are actually share a common origin or they are separate disease. Although most of the data I will expose now in favor that both are separate disease, but still I have some data to suspect that both may share a common origin. First of all, as all of you know, that still there is a considerable sector of patients who show overlap between asthma and COPD. Again, the new guidelines for COPD had changed the concept of definition of COPD from being completely irreversible in the past, and now in the new guidelines, they are talking about partial reversibility in COPD patients. My third point about the common origin of both disease, that I had 3 years large scale study in our department about cases of refractory asthma, and we found that bronchoalveolar lavage of those patients with refractory asthma, starting in their lavage to increase the constituent of 2 of the inflammatory cells of COPD. I mean the neutrophils, which is the joker cell of inflammation in COPD. It starts to appear intensively in the bronchoalveolar lavage of patients with refractory asthma. Again, CD8 lymphocyte, which is a known cell of COPD, starts to appear intensively in the bronchoalveolar lavage of cases with refractory asthma. And I had 2 slides for this I exposed half an hour ago in the last session about the CD8 intensive infiltration in the submucosa of refractory asthma and also neutrophil. So these are the suspicious data about the common origin of both diseases. But on the other hand, before exposing the data that emphasize that both diseases are separate diseases, I would like to ask if we are in need actually to verify both diseases from each other during our practice, or there is no need to verify both. So I will start by differentiating both data from our daily life. We know that the reversibility is sure among asthmatics, while in COPD, reversibility is not present at all, or at least small element of reversibility. The smoking history is nearly always present among COPD patients, while it is not necessary to be present among asthmatics. The late onset of disease, I mean the age of the patients for the start of COPD, is always late onset, while asthma can start at any age. Sometimes it's more common or it is common in childhood period, while never COPD to start in childhood period. Again, while the dyspnea, and this is very important, is progressive in COPD, it shows variability even in the same day among asthmatics. The disability, I mean the quality of life, is progressively declining in COPD, and it is intermittent in asthma and variable also. The early death or the death rate is more in COPD than among cases with asthma. Atopy is a feature commonly associated with asthma while not in COPD, and also airway hyperreactivity or hyperresponsiveness is a constant feature among all asthmatics while it is not present in COPD. The occupational history sharing both disease, asthma and COPD. This slide shows the effect of smoking on the decline in FEV1. This is the non-smoker rate of decline, and this is the rate of decline in a smoker. And I have one paper saying that the rate of decline in smokers in FEV1 above the age of 35 years, it is about 30 ml per year among the non-smokers, compared with 50 ml per year among the smokers. So nearly the double the rate of decline in this one. And you can see, I don't know if it is here apparent, this is the rate of decline here. I'm sorry because it's not very clear. The rate of decline of the FEV1 in COPD with the advance of age. Concerning asthma, the peak expiratory flow record even in the same week, or you can see here that it is variable peak expiratory flow record with a morning dipping always, as you notice here, but the fluctuant records for this is not a feature among COPD, but only among asthmatics. This is the comparison of the records of function being variable in asthma and being progressively declining in COPD, whether smokers only and COPD. This is comparison of the rate of declining of the FEV1 in smokers and COPD, and still the rate of declining in FEV1 is much more in smokers with COPD rather than in smokers only. And here the rate of declining in asthmatics still is more than the smokers, but it is not that of the COPD patients. What is interesting is the overlap, as I mentioned in the start of my lecture, about the overlap between asthma of COPD concerning the rate of declining in FEV1. So another point to differentiate between both diseases that refer that both diseases are actually two separate diseases. As you see here, all of us, we know that asthma, as COPD, it is mainly a disease of the small airways. And this is in COPD, a histological picture or pathological picture for one of COPD patient showing mucus gland hyperplasia compared with the mucus gland of the normal. And you can see here one of the pathological elements of COPD, that the mucus gland hyperplasia. And the other element is the small airway thickness with alveolar disruption, alveolar wall. So these are the main three pathological elements in COPD: mucus gland hyperplasia, small airway thickness, and alveolar wall disruption. Concerning asthma, asthma is mainly a disease of the large proximal airways rather than, of course, there is element of affection of the small airways, but this is not the main brunt. The main brunt on the proximal large airways. And the main pathological changes in asthma, as you see, the smooth muscle hypertrophy, and this is a section of one of the patients with asthma with this hypertrophy of this bronchial smooth muscles compared with the normal thickness of the bronchial smooth muscles. One of the most interesting points to me, because we stressed upon, is the basement membrane thickness. All of the cases with refractory severe advanced asthma show thickness of the subbasement membrane, while none of the cases with COPD showed that thickness of the subbasement membrane. This is very interesting point for comparing both. Thickness of the subbasement membrane is completely absent in all cases of asthma, whatever the severity and the stage, while it is evident, it's completely absent in all cases of COPD, but it is completely always present in cases of severe asthma, and even some claim that the thickness of the subbasement membrane even starts early in asthma course. This is the T cell lymphocyte infiltration characteristic CD8 in COPD. And as I said before, that cases with COPD shows CD8 T lymphocytes high compared with normal, and macrophage high compared to normal, rather than the increased number in CD4. CD4 is characteristic more for asthmatics. To complete the comparison between asthma and COPD concerning the mucus inflammation, as I mentioned, CD8 level is high in COPD, while it is not high, this is not low, but it's not high in asthma. CD4 is more infiltration in asthma rather than in COPD, and the ratio, of course, CD4 to CD8 is high in asthma while it is low in COPD. Macrophage is more important cell in COPD rather than in asthma. Eosinophils level is high in asthma than in COPD, while interleukin 4 and 5 more in asthma, while it is not that high in COPD. On the contrary, interleukin 8 is high in COPD, while is not that high in bronchial asthma. All of these data referring that both are not one disease actually. This is the neutrophil level during exacerbation. And also during exacerbation, what's interesting that not only neutrophil level increased compared with the stable disease in COPD, but also eosinophil level, it increased during exacerbation of COPD, and this might be one of the concepts of application of ICS in patients of COPD with acute exacerbation recurrent, is the increase in the number of eosinophils during acute exacerbation. The guidelines from the GOLD and from the ERS-ATS combination, it actually referred by definition to COPD as a preventable and treatable disease characterized by airflow limitation that is not fully reversible. This was not the statement in the past. In the past, we were talking about irreversible. Now they are talking about not fully reversible because of the overlap between the asthma of COPD, but still it is the airflow limitation is progressive, and the response of the lung to noxious particles or gases and to cigarette smoke is of primary importance in COPD. And for the diagnosis of COPD, you depend on the productive cough history together with the dyspnea and exposure to the risk factors, and particularly smoking. Spirometric studies is vital in COPD even rather than in asthma, and also the irreversible pattern is very important in the diagnosis of COPD. And about the management of COPD in guidelines is completely different from that of asthma. It includes, besides the pharmaceutical or pharmacological therapy, the long-term oxygen therapy. This is one of the important guidelines in COPD and not very vital in asthma. Pulmonary rehabilitation, nutritional status, and surgical rule in COPD. Nobody mentioned surgery in asthma, and the sleep studies and CPAP role with the concern about the air travel of COPD patients, especially those with critical levels of oxygen saturation. And for the pharmaceutical treatment in differentiating both COPD and asthma, I'm not going to talk about the guidelines of treatment, but only to concentrate that in asthma, all of us, we know that whatever the stage of asthma early, we have to start ICS for asthmatics. But for COPD, the guidelines refer to ICS only for the severe and very severe patients with COPD and among those with recurrent exacerbation. And now the question for discussion still, is it crucial to differentiate between asthma and COPD as they need different treatment approaches or not? And thank you very much.
Thank you very much بروفيسور طارق محفوظ. الحقيقة أنت قلت لنا فروق واضحة قوي بين الأسما والسي بي دي، لكن still we don't have a sharp line between both، ولسه مازال عندنا جراي زون واسعة فيها يمكن 10% من الحالات، ويمكن حلها ان الليتست ريكومنديشنز بتاعت الاي تي اس واليوروبيان ريسبيراتوري سوسايتي جوين توجذر قالوا ان اذا احنا كونفيوزد عالج الحاله على انها اسما، بدل ما نبقى قاعدين نقول اسما ولا سي او بي دي، لان ده كلينيكالي ان براكتس بنقابله كتير. فعلى الرغم من طبعا حضرتك عرضتها جميله قوي، لكن على الرغم من كل الكلام ده still we don't have this sharp line. يعني مازال مطروح، ويمكن الخلفيه اللي ورا الكلام ده منتظرين بقى استاذ الدكتور حاتم ملواني يجاوب لنا عليها. الخلفيه هي هندي ستيرويدز ولا ما نديش، هو قالها بطريقه هاملت ICS to be or not to be. الله
رجع في كلامه
What's there in the
خايف يلخبط بينهم وبين
لا now we'll start the act of the play of Hamlet. Okay.
We'll start.
بسم الله الرحمن الرحيم. Mr. Chairman, colleagues, ladies and gentlemen, we all confess and we agree that bronchial asthma is chronic inflammation, and so the cornerstone in management of asthma, if any, should start by control of this inflammation. And back to facts, we know that even in the early stages of asthma and in patients who are not still experiencing the clinical manifestations of asthma, if you get a biopsy, you will find the inflammation. And this might be very intense. Another important and very serious fact is that even in children who have still a very recent history and short duration of asthma, they may have severe inflammation even amounting to remodeling. So here, if the inflammation is so extensive, remodeling may occur in children and regardless of the duration of the asthma. Again, about prevalence of asthma, we know that bronchial asthma is not a reportable disease, so there is no very precise estimation of the prevalence of asthma. What's available is the WHO publication some years ago in some countries in North Africa, including Egypt. And you can see that the mean prevalence of clinical asthma, now we are talking about clinical asthma, and no mentioning of the inflammation as it is suggested by biopsy, it's around 4%. But I think we all agree that we have the impression that this figure is actually representing an underestimation. And this underestimation is due to so many factors. And we heard so many figures, something between 8 and 10%, so I think 9% might be accepted as a reasonable figure. Asthma is a common cause of emergency room visits and hospital admissions, and this will impose very much costs on the health resources. And the burden of asthma is higher than generally recognized, particularly in children, and up to 1 in 4 children are going to miss their school because of asthma manifestations. And the guidelines, as well as many national guidelines, recommend a stepwise approach to asthma therapy, and they are directed towards achieving suppression of airway inflammation. This is the core of the whole subject of asthma. This is inflammation. You have to suppress the inflammation. In this way, you will reduce the asthma manifestations, and probably you will guard against the development of remodeling, which is supposed to be irreversible. And we are acquainted with this, and you have to select some of medications. And to select this or that, you prefer this or that, this will depend on your experience, and this will depend on individual response between the patients. But as you can notice, the inhaled steroids in a stepwise fashion, you increase the dose, is a cornerstone in the management of inflammation of asthma. So again, inhaled steroids are cornerstone of asthma therapy, and all guidelines state that ICS are the cornerstone of therapy for persistent asthma of all grades of severity, whether in adults or children, and no other currently available therapy is as effective in controlling the underlying inflammatory process of asthma. Examination of bronchial biopsy, as I've stated 2 minutes ago, indicates that significant inflammation is present, even in the early steps of asthma and in those patients who have symptoms for a short time and in those with the disease which is considered as mild. This is the histopathology of asthmatic patient. You can see how disruption and discoloration of the epithelial lining occurs, and it seems that reversibility even of these histopathological changes will be achieved by the early use of steroids. We know that there is underuse of ICS by patients everywhere, globally speaking, in Europe, in the States, everywhere. Patients do not use ICS, and whatever you do, medical and continuous medical education, most of the people, they failed to convey this message. Please use ICS early. In so many studies, up to 70% of people with asthma, still they use the inhaled short-acting beta-agonist. They don't use the longer-acting beta-agonist and ICS or anything. Of course, we appreciate that people are afraid from the side effects of asthma, and this is the job of the treating physician. You have to inform him and to convince him that you are actually you are using a topical use steroid, no much systemic bioavailability, misunderstanding of their disease. They consider that whenever they have symptoms and they wheeze, they have to use the medication. No, even your patient seems to be normal, still inflammation is going on. And finally, many patients overestimate their degree of control and have a perceived lack of need of medication. This is actually a very serious problem. The patient has a very false sense of security. So long as he has no symptoms, he feels that he is secure. And so many patients who feel to be secure, they are not on longer acting, on longer term therapy with ICS, they are quite free. But once they get attacked, this might be very severe. It may send him to ICU and mechanically ventilated and may pass away. The relief medications and underuse of ICS by asthma severity in different studies in Europe and in the States, they show that still the use of risk medication takes the upper hand in the different steps and the stages of bronchial asthma. But whenever you use ICS in the early phases of asthma, you will succeed to get marked improvement in peak expelled flow rate, which will reflect good control of asthma. This is a very important slide which shows the effect of an example of ICS, which is budesonide, one of the important and eminent ICS actually. The effect on the morning PAF will start by the small dose of 200 micrograms. 400 micrograms seem to be a very reasonable dose, and the maximal effect will be achieved when the dose is 800 micrograms. But as it is very well known and appreciated, in the field of use of steroids, whenever you increase the dose, you expect to have more effect, till a plateau. And here is a situation, a plateau effect has been achieved. That's to say, if you increase the dose up to 1600 microgram, no much effect different from 800 micrograms. And possibly this does not reinforce a recommendation or an option of guidelines instead of ICS and low dose of ICS and the LABA, just double the dose. No, we don't recommend doubling the dose. You have to use ICS and the LABA or ICS and leukotriene modifier. Two anti-inflammatory with two different mechanisms of action are much, much more efficacious than doubling the dose of ICS. And globally speaking, the clinical symptoms and the measures of lung function will be improved with increasing the dose again till a maximum of 800 microgram. Again, what about death from asthma? We expect that whenever the patient uses more and more canisters of ICS per year, the mortality rate will decrease, reflecting a good control of inflammation and the scenario of bronchial asthma. Are all ICS the same? What we have in the market, globally speaking, fluticasone and budesonide. These are two very familiar ICS. And in general, any drug you use, you will rely on efficacy and the safety of the drugs. If you compare the two ICS, the efficacy will depend on the small particle size, the high glucocorticoid receptor binding affinity. This is a crucial point. Whenever the glucocorticoid receptors, they are very hungry for the ICS you are giving, high affinity will mean high efficacy. And finally, you need your ICS to remain for a long time in the lung to act at the target level. So this would refer to the lipid conjugation. Lipid conjugation will allow ICS to remain longer in the lungs, and bisonide actually is the only one that has shown to undergo lipid conjugation, which will ensure that it will remain for a longer time at the bronchial level. On the other hand, what about safety? Safety will depend on the clearance, systemic clearance, the degree of oral bioavailability, which will be followed by availability in the stomach and in the systemic circulation, and the low oropharyngeal exposure. Back to the two kinds of ICS. Here you find that such an ICS, such as fluticasone, it has a high lipophilicity, which will mean that it will be attracted by a lot of the systemic tissues. So it will not be just confined to the blood to be cleared through the kidney. No, some or a big amount of the drug will be attracted by the tissue. Compared with bisonide, this is a low volume of distribution with the least amount of distribution in the tissues, and this will be followed by the element of elimination. What about half-life? Bisonide has a shorter half-life than fluticasone, which ensures rapid clearance from the blood. Distribution into tissues, it has a lower distribution into tissues if compared to fluticasone. And what about oral bioavailability? Of course, we all know that the ideal ICS would have minimal oral bioavailability, reducing the likelihood of systemic adverse effects, because whenever it is available in the buccal and oral spaces, this will be swallowed, and so it will be absorbed from the stomach, rendering it available in the systemic circulation. And the elongated piece of the aerolyzer will ensure more or less direct exposure of the bronchial tree to the powder rather than the oral cavity. And what about hypothalamic pituitary adrenal axis? This is the top of the systemic bioavailability. You see that bisonide has less effect on the hypophyseal pituitary axis. It does not suppress it to a great degree, and this will be reflected on its effect on children. No effect actually markedly on the growth of the children. What about safety in pregnancy? As I think bisonide, according to ESSB, this is FDA approved to be used in pregnancy. And please tell your patient about this point who are afraid of the ICS. So whenever a drug can be prescribed during pregnancy, this is considered to be relatively safe. And finally, the message is that inflammation is going on in asthma. Don't consider that the case is early or late in any phase, and particularly in the early phase of asthma, you should not hesitate to use ICS. And thank you very much.
Thank you, Professor حاتم. انت قلت لنا ان هو to be في الازمه. to be مش انت to be or not to be. رجع في كلامه وانا قلت لك. رجع في كلامه.
انا قلت هتحلها لنا وتقول لنا to be.
فالفلور is open for discussion، وهنبتدي بالمنصه. الاستاذ دكتور محمد عوض تاج الدين، اتفضل حضرتك.
شكرا. امبارح في نفس المكان وفي ذات الساعه كنا بنناقش موضوع البرونكيال اسما، واللي حضر من حضراتكم قلت لكم، كان الدكتور طارق برضه بيتكلم طارق محفوظ، قلت لكم ان السير ويليام اوزلر سنه 1893 ديفاين الاسما بنفس الباثولوجي اللي احنا بنتكلم فيه في نهايه 2007 وبدايه 2008. الأستاذ الدكتور طارق صفوت عرض inhaled corticosteroids لابا اللي هي long acting beta agonists ولا inhaled corticosteroids وانتي ليكوتراينز، ووصل لكونكلوجن في البرونكيال اسما ان ودي الحقيقه البراكتيكال. انا نفسي ان انا اصل معاكم ان احنا مبقاش في ديسكريبنسي ما بين ما نسمعه وبين ما نفعله براكتيكالي في العيادات بتاعتنا او في المستشفيات. وامبارح برضو اخر حاجه قلتها ان احنا اتفقنا ان الباك بون بتاع المانجمنت بتاع الاسما هو inhaled corticosteroids و long acting beta 2 agonists و short acting plus with or without anticholinergic when required. وده البراكتيكال اللي احنا بنعمله. فاحنا اتفقنا بيزيكالي ان الانهيلد corticosteroids واللونج اكتنج بيتا اجونستس لان العيان بتاع الاسما بيجي له برونكوسبازم، هو مانيفستد ببرونكوسبازم. وقد نحتاج مع كل الريكومنديشنز ان احنا نضيف انتي ليكوتراينز او ادويه اخرى في بعض الحالات. الاستاذ الدكتور طارق محفوظ اتكلم على سي او دي واسما، هم ديزيز ولا ديزيزين؟ طبعا هم تو ديزيز ديفرنت ديزيز. وهرجع تاني، وانا في الماضي القريب كنت في ديبيت قوي جدا مع one of the eminent international speakers مع الديفينيشن الجديد بتاع chronic obstructive pulmonary disease. كنت هقوله انا النهارده وبعدين قلت نختصر الوقت. هم نفس الديفينيشن اللي من عشرات السنين ضافوا عليه حتتين جداد، قالوا preventable and treatable. فانا قلت لهم لازم تحطوا it is not curable. هو preventable، طبعا preventable ممكن نمنعه، لكن اذا حصل هرجع تاني للكلام اللي انا بقوله دايما، لن يصلح العطار ما افسده الدهر. وهذا لا ينطبق على البرونكيال اسما، لان البرونكيال اسما في كثير من الاحيان it's reversible disease، ولما بتبقى irreversible يبقى دخلنا في components اخرى. لكن هي اسما الاسما معروفه والسي او بي دي معروفه. وبعدين ده مش عائد للدكتور طارق، ده عائد للي عملوا الديفينيشن لما قالوا كانوا بيقولوا زمان مفيش ريفرسبيليتي. لا، ده طول عمرنا بنقول ان في بارشا ريفرسبيليتي. وكنا دخلنا مره في ديبيت ازاي في بارشا ريفرسبيليتي. ارجع للكومبوننتس اللي اتشالت من الديفينيشن، عشان كده البرزنتيشن بتاعتي بحط الاولد ديفينيشن والنيو ديفينيشن ان هي 3 كومبوننتس: كرونيك برونكيتيك كومبوننت واسماتيك كومبوننت وانفيزيماتس كومبوننت. الانفيزيماتس definitely irreversible. الكرونيك برونكيتيك كومبوننت is partially reversible. والاسماتيك كومبوننت ممكن تبقى completely reversible. هو ده الكرونيك اوبستراكتيف ايروي ديزيز. كانوا بقى كل شويه يغيروا الديفينيشن، كل سنه يقعدوا قاعده محترمه ويغيروا فيها، لكن ما زال الكرونيك اوبستراكتيف ايروي ديزيز هو الديفينيشن هو بريفنتابل وتريتابل وكنترولابل but not curable. طب ندي ايه؟ نعمل بريفنشن، واحنا عاملين كامبين قوي جدا جدا متزعمينه عشان انتي تباك سموك، وعاملين قوانين ومقدمين قوانين المجالس التشريعيه عشان نمنع التدخين في الاماكن العامه. لكن ستيل يا دكتور طارق في بارشا ريفرسبيليتي في الكرونيك، انت زي ما انت قلت يعني كرونيك اوبستراكتيف ايروي ديزيز. هل في رول للكورتيكوسترويدز واللونج اكتنج بيتا اجونست في الكرونيك اوبستراكتيف ايروي ديزيز؟ بالحته اللي انا قلتها طبعا في رول، لان في اسماتيك. حتى لو احنا بنتكلم زي ما قال الدكتور طارق ان في نوع من الانفلاميشن مختلف شويه في الكرونيك اوبستراكتيف ايروي ديزيز، هو مختلف عن الاسما، لكن ديفينتلي اتليست عندي اسماتيك كومبوننتس. بدليل انا بكلمكم على العيانين اللي بنشوفهم، ان العيانين لما بياخدوا هذه الدراجز بيبقوا كنترولد. صحيح يقول لي طب انا لسه نفسي مكروش، اقول له قول لي الزمان يرجع يا زمان. ما هيصلح ازاي نفسه؟ لان هو عنده انفيزيما وعنده بريفرال برونكوسبازم. حتى لو صدره ما بيزهقش قوي تعمله الفانكشنز تلاقي سمول ايرويز اوبستراكشن. فاذا هناك رول لهذا. نرجع للدكتور حاتم الملواني، بي اور نوت تو بي؟ هي تو بي. تو بي طبعا في كثير من الاحيان. اذا ما فيش لخبطه، ما فيش ديسكريبنسي بين كلامنا، لان الاسما از اسما والسي او بي دي السي او بي دي، والسي او بي دي هم الحقيقه 3 ديزيزز مع بعض، لكن هم سندروم حتى لو قالوا بتوع الجولد غير كده. شكرا.
هي في بس كومنت صغير على الريفرسبيليتي. هو احنا الريفرسبيليتي احنا ايه الميزان بتاعنا؟ الميزان بتاعنا الاف اي في 1. اف اي في 1 ممكن تفيدنا في الاسمى، لكن في السي او بي دي الكلام الابحاث الدقيقه دلوقتي، وزي ما حضرتك قلت انها مشكله في السمول ايرويز rather than the major airways، الكلام كله دلوقتي على the peripheral airways وعلى الانسبيراتوري كاباسيتي اللي بتبقى بتقل on the expenses of the air trapping. وبالتالي احنا لو اعتمدنا عليها وابتدى يتعمل لها دلوقتي جريدز، وفي ناس قسمت السي او بي دي المايلد ومودريت وسيفير وفيري سيفير according to the inspiratory capacity. لان احنا ما بندي برونكو دايليتور احنا عندنا نوعين من العيانين او نوعين من الاستجابه في العيانين، في فلو ريسبوندر وفي فوليوم ريسبوندر. يعني اقيس الاف اي في 1 عنده او الفلو ريتس ولا ما اتغيرش كتير، لكن لما ابص على الفوليوم الاقي هو اتحسن قوي لان حصل ريليس للاير اللي ترابد ده في السمول ايرويز اللي ما هياش حساسيه الاف اي في 1 لقياسها عاليه، وبالتالي العيان ده سبجكتيفلي بيقول انا اتحسنت على الرغم من ان الاف اي في 1 بتاعته ما اتحسنتش، لان الاير اللي ترابد ده لما بيبقى ترابد بيستيميليت ريستريتش ريسبتورز فبيديله السنس اوف ديسنيا، اما بيفك بيبتدي يحس سبجكتيفلي انه احسن، ولما نقيس الاي سي هنلاقي انها بقت احسن. وبالتالي ده برضو يمكن كمان شويه يبقى واحد من الفروق ما بين الاسما والسي او بي دي. لكن انا مصره ان احنا في عندنا حته كده كبيره في النص احنا مش بنعرف نفرق كلينيكالي. هم
الثلاث حلقات بتوع زمان يا دكتوره ميس، انا مصمم عليهم. الحلقه الاولانيه اسماء، والثانيه سي او بي دي، والثالثه انفيزيما، وبينهم الجري زون. برضه الحته دي هترجم لكم شويه الكلام الكبير الحلو اللي لقيته دكتوره ميس. دكتوره ميس قال كلام حقيقي ان كل اف 1 فيه كونتينوس ديكلاين حتى لو العام بياخد علاج، يقل بقى ملي 2 3 زي ما يقل، هي محسوبه. لكن الريفرسبيليتي هنا از بارشال ريفرسبيليتي، بمعنى ان ممكن يجي لك واحد النهارده سي او بي دي تعمل له اف في 1، العمليه نسبيه يا جماعه، تعملها له تطلع مثلا سي 50%، هو انت عايز 80 85 90، وبعدين يجي له اتاك تنزل 40% زي الاوكسجين زي الساتوريشن وزي البي او 2. لما تعالجه بدل ما كان نزل 40 ممكن يرجع 49، فدي اسمها بارشال ريفرسبيليتي. هو ما رجعش زي ما قلت لكم، بقول لكم كل الزمان نرجع زمان، ما رجعش زي الاول، لكن اتحسن نسبيا، وبعدين المزيكا اللي في صدره راحت. ما هو ده نوع من الريسبونس. مش هنطول عليه.
دكتور سمير خالد.
الحقيقه يعني ليه وجهه نظر هتريكونفيرم الكلام اللي اتقال قبل مني. احنا بس لازم نتفق عن الازمه ما بقتش وان ديزيز، لازم نعترف بالهيتروجينيستي اوف ازمه. نمرة 2 الاد اون اللي قاله الدكتور طارق والكونكلوجن الجميله اللي قالها انا موافق عليها تماما، بس في حاجات بتفسر لنا ليه الكلام ده. احنا لما نعرف الموست كومن كوز اوف اكسسربيشن بالنسبه للازمه اللي هو المايكرو فاسكولار ليكج. المايكرو فاسكولار ليكج ده بيبقى تحت تاثير 3 حاجات: الفاسكولار اندوثيليال جروس فاكتور، وحاجه اسمها الانجيوبتين 1 اند انجيوبتين 2. معظم الاكسسربيشن اللي بتحصل في عين الازمه بتبقى في الانجيوبتين 1 والفاسكولار اندوثيليال جروس فاكتور، وده بيرسبوند لللونج اكتنج بيتا 2 اجونست. الجزء الثاني بتاع الانجيوبتين 2 ده اللي بيرسبوند للانتي ليوكوتريه، دول 75% دول 25%. اذا اللي قاله الدكتور طارق بيخضع للقانون بتاع الاميونوباثولوجي اللي بدا يطلع في البابليكيشن بتاعت الايام دي. الجزئيه الثانيه اللي انا عاوز اقولها فلسفه الاد اون. مش كل العيانين زي بعضهم، صحيح معظم العيانين اللي احنا بنضيف اللونج اكتنج بيتا 2 اجونست على الانهيلد كورتيكوستيرويد بيبقى ريسبونس فيهم احسن من الليكوتريه، الانتي ليكوتريه. ليه؟ لان العيان ده نوعين: عيان عنده impaired translocation للكورتيكوستيرويد، يعني الكم بتاع الانهيلد كورتيكوستيرويد ما وصلش، يبقى ده لو اعطيته لونج اكتنج بيتا 2 اجونست هتزود الترانسلوكيشن، يبقى الكورتيكوستيرويد هيشتغل، ودول عددهم كبير، عشان كده اللابا احسن من الانتي ليكوتريه. في بقى نوع تاني ودول نسبتهم 20% برضه، بيبقى عندهم ديفيشنسي في انزيم اسمه هيستون دي اسيتاليز، ضفت لابا مش هتشتغل، يبقى هيستون دي اسيتيليز. هيستون دي اسيتيليز ده
المهم اللعبه تشتغل. مش مهم اسمه
5 هيستون.
ده لما يحط له اولترناتيف انتي ليوكوترايين او سايوفيلين حتى هيشتغل. يبقى هنا لما نيجي نقول اد اون لمين؟ صحيح احنا ما بنعرفش ومحدش هيعمل انفستيجيشن في الديلي براكتس، انما دي الفلسفي او الباثوفيسيولوجي بتاعه الاد اون. حبيت بس اوضحها لحضرتك. شكرا جزيلا.
هنكمل الدسكشن بقى في النكست سيشن اللي هي الريل لايف اكسبيرينس. ومي اي كول فور تشير بيرسونز بروفيسور طارق صفوت وبروفيسور طارق محفوظ والاستاذ الدكتور محمد السوية ابو شحاته والاستاذ الدكتور سعيد حمزه والاستاذ الدكتور نبيل فؤاد. كل